Welcome to start of Brain Health Awareness Week. It's a full house, which is, I guess, good and bad. I apologize for the tight accommodations here. But I think you're in for a treat, an exciting day, and in fact, an exciting week. My name is David Park. I'm the director of the Brain and Mind Research Institute at the University of Ottawa. Again, welcome to all, and some have come from out of town, so we really greatly appreciate you coming. Just a few words before I introduce our honored guest. So just to recap, the Brain Institute here is really dedicated towards understanding brain disorders and understanding the brain. It's an incredibly complex cell organ, as you all know. And we do this by really collecting all the expertise in Ottawa and organizing them together to paddle in the same direction. And this is incredibly important and an incredible part of trying to understand the complexity of the brain. So, welcome again. I'd like to say this is our 4th year doing this, and a shout out to the organizers of the Brain Institute, Natasha, Rosemary, and others. Thank you very much for doing this. And so without further ado, I'd like to introduce Councillor Jean Cloutier. I want to just briefly mention that the first Brain Health Awareness Week and each year thereafter was done in conjunction with the City of Ottawa. So the City of Ottawa was incredibly gracious to partner with us for the first year and continues to do so. So as part of this partnership, every year the City of Ottawa reaffirms the partnership with a proclamation. And so, City Councillor Jean Cloutier from the Alta Vista Ward, please come up, and thank you so much for doing this again.
Thank you very much, Dr. Park. Merci énormément, Dr. Park. It is always a pleasure and a privilege to be here. It is especially a pleasure and a privilege to have the General Hospital, CHIO, this health complex in our ward in Alta Vista. And while there are many federal and provincial issues, there are also some municipal issues, the nuts and bolts of what makes an organization like this work, transit and things like that. So it is truly a pleasure to be of assistance as best I can to the residents, to this organization, to this very important organization. And as we're looking for economic development, as you might know, the mayor was in Seattle to Lower Amazon, to Ottawa. Organizations such as this, the University of Ottawa, the Ottawa Hospital, all our organizations are part of that web that makes Ottawa the great place for residents, for researchers, for professionals to come and work. And all that with the goal to be of assistance to our residents who require the services. So, without further ado, on behalf of Mayor Watson, I'd like to read the proclamation. Whereas brain and mind-related illnesses affect 1 in 3 Canadians of any age, whereas the socioeconomic cost of brain and mind-related illnesses is enormous in Canada and worldwide. Entendu qu'Ottawa, avec à sa tête l'Université d'Ottawa et ses établissements de recherche et hôpitaux associés, est un centre national de recherche sur le cerveau et l'esprit, whereas Brain Health Awareness Week will aim to improve public awareness and reduce the stigma associated with brain and mind-related illnesses. Therefore, I, on behalf of Mayor Jim Watson, par conséquent, moi, pour le maire Jim Watson, do hereby proclaim October 16th to 20th, 2017 Brain Health Awareness Week in Ottawa and call upon all citizens to mind their brain.
So we have a very, very incredible day today with 3 speakers. I'm going to act as a semi-MC to introduce the first speaker, Dr. Mark Freedman. So Dr. Mark Freedman is currently a professor of medicine in the field of neurology at the University of Ottawa, as well as director of the MS Research Unit at the Ottawa Hospital General Campus and senior scientist at the Ottawa Hospital Research Institute. So he will start us off by really talking about the first topic in terms of some of the amazing things that are going on in Ottawa for MS. So, Mark?
Thank you very much, David. It's hard to really hit these topics with such a short time period, but I was hoping to at least stimulate some interest and share with you some of the things that we are doing here and what we hope to gain from them. Since the topic is about stem cells, I thought I would start off by at least discussing what we mean by a stem cell and the confusion that we've been facing with so many different patients thinking that all stem cells are the same and that the stem cell programs that we have here are similar, and they're extremely different. And so I'm going to try to at least distinguish these for you. Obviously, there's a lot of hype in this, and I couldn't believe how many more centers have now cropped up in the United States offering stem cells for various types of treatments, including multiple sclerosis. I've even heard of a stem cell center not far from here in Kingston that's actually offering stem cells for orthopedics, although at least the evidence for that is a little bit better than some of these shaky places that have opened up for the sole purposes, of course, of sifting money from desperate people and offering hope where perhaps what they're offering is not going to provide it. So let's talk about what stem cells are. And it turns out we all have them. In fact, we've always had them, and just people didn't realize that they were actually buried in our tissues. But what makes them a stem cell is the ability to self-renew on a regular basis, and they are what's called pluripotential or totipotential. These are just jargon words, but they are keeping the ability to become anything that the body needs. So think of it, all of you here started out from one cell, that's right, and then you ended up with a whole mass of cells that looked exactly the same, and then at some point, some of these cells became your liver and your heart and your brain and your skin and your blood. How did they know how to go that route? What directed them? How did they change? All cells start out the same. They have the same DNA code, but yet some of them have decided that they would become a tissue-specific cell. Well, it turns out we still have those cells, and we always have them with us, and it's harnessing them that has become the art in recent times. So these new differentiated cells, the ones that become different organs, they can become the cell of the liver or the brain or the blood, however you want them. But there are other properties that we've been able to get from them. Some of these cells have the ability to control inflammation naturally, and some of them have the ability to repair. And we'll talk a little bit about that. So these are some of the words that you're going to hear or you read about, the so-called totipotent or pluripotent or multipotent. But you can see as we go from the left to the right on this slide, all the cells are totipotent when you're just a big mass of cells after you've been fertilized. And then at some point there's a little inner cell mass. I don't have a pointer here, but I guess I can use this thing. No, maybe I don't. Doesn't show up. But in the middle there, in the pluripotent, there's a sort of like a little mass there, and there's cells off to one side. And that's really where things start to evolve, and then you can see a little embryo start to form, and then before you know it, you're into the differentiated human on the right. And as you go from left to right, you lose a little bit of that ability to turn into other types of cells. So if you want to talk about the brain, there are at least several types of brain neural stem cells that you can derive from. You can take them from embryos, and that's got its own little issue. We can just touch on that. You can actually convert any cell of your body into a stem cell. They're called induced pluripotential stem cells. The person who discovered the 4 factors that did that won the Nobel Prize a few years ago. You can actually harvest stem cells from a developed brain or from an embryo, or you can grow them, and you can grow them out of tissues like the bone marrow, or you can grow them out of other tissues such as your fat. They've even been able to grow them out of teeth, believe it or not. So I won't going to really touch about the embryonic stem cells because that's a whole little issue in itself and has some ethical concerns as to just when an embryo is no longer a group of cells. And I think I'll just leave it at that. So the induced pluripotential stem cells, they're very interesting. But you can see here there's a bunch of reprogramming factors, and one of those factors happens to be an oncogene. So that means it can convert a cell into a cancer cell. And because some of those factors are working very nicely in a petri dish, nobody's been able to show that the transformed cells don't carry any risk. And so they're not quite ready for human consumption, but they certainly are useful for researchers to develop stem cells to play with and learn from in their in vitro cultures and be able to develop perhaps therapies that then might be used in people. But you can see at the bottom here all the critical layers. Thank you very much. Okay, all the critical layers that make up our body can be developed from these induced pluripotential stem cells. And then the sky's the limit, isn't it? You know, at one point we might be in a situation where we could just simply go and pick up whatever we want. And that's where the hope will lie from this. Now when we talk about the neural stem cells, around the ventricles, especially in an embryo, there are lots of these, and you can actually grow these out into neurospheres. And then we know all the factors that are necessary to take these cells and convert them to any of the three major cells of the brain. And the one of interest to us in multiple sclerosis is the middle one here. That is the oligodendrocyte, which of course makes myelin. So as a result of this, people are reaching out to stem cells and thinking about their use in multiple sclerosis, but they're not all the same. So for instance, using mesenchymal stem cells, which I'll tell you about shortly, there's a lot of hope that these cells will not only control inflammation, but also promote repair. That's very different than simply drawing down on the bone marrow, isolating stem cells. By the way, one of the first stem cells ever discovered was a bone marrow stem cell that gives rise to all the red and white blood cells of our body. It was way back when they couldn't even identify them with the markers that we have today. They were identified by their behavior under a microscope and their ability to form small colonies. So that was one of the first stem cells that were ever discovered. Those cells are simply harvested straight. Nothing's grown, but they're used to replace a bone marrow that is either diseased with cancer, like leukemia, or giving rise constantly to an autoimmune process like MS. If we can eradicate the disease-causing cells, since we don't know what they are, we eradicate everything, and then you still have to replace it, you use these replacement cells. So mesenchymal stem cells you can grow, you have to grow because there's very few of them, and that requires a culture facility. But for replacement, you don't need to do anything. You just simply collect them, and then they're replaced. So this is the niche, so to speak. This is in your bone marrow. You get all these stem cells that can give rise and completely replace your red and white blood cells of the body. That is what we are doing in our bone marrow transplant program that you've heard about. And now the Brits have thought about it themselves, and you start to see lovely little anecdotal cases of people who've done very well following a bone marrow transplant. I'll just tell you a little bit about our program for this. We undertook this some years ago when the frustrations that we had as MS clinicians and the researchers have never been able to identify the same thing in two people, and the heterogeneity that is seen throughout the disease really doesn't allow us to come up with a therapy that will go for everyone, because the problems are different in every single case. That makes it very difficult to, say, develop a one-shoe-fits-all therapy. But since we don't know what the problem is in everyone, and we know the problem lies with the immune system, we had the ability to simply take it out and replace it de novo. Similar, I use the analogy of going and buying a new car and the air conditioner doesn't work. You've taken it back 17 times to the service price, and finally they said, you know what, we can't figure out what's wrong with it. We'll just replace it. And I think that's kind of where we were with MS. When you have this technology, let's use it. So using the poisons that the oncologists have harnessed for years to treat leukemia, they know how to very methodically get rid of a diseased bone marrow. And then you're left in a situation where you have to replace it. And now you can do that because before you go and blow it all away, you can harness the stem cells and actually put them aside. And then after the diseased marrow and cells of the body are removed, you simply bring in those stem cells and they repopulate and develop into a brand new immune system that supposedly isn't going to trip up and make the same mistake again. Turns out these cells are capable of just a little bit more, and some of these cells may actually have the ability to repair, although no one's really been able to show that. So what we've done is we've used this, and in the first trial, we really had to choose patients who were very early but very aggressive, not responding to the typical types of therapies, because there was risk associated with the procedure, and it was not considered ethical to offer such a risk to people who would otherwise have a very mild disease. And so they take some drugs for a little while, and then we put them on a machine, like the one on the left here, literally one line in, one line out, and the cells go through this machine, and we collect the stem cells along with a lot of other cells. And then we use a purifying device, as shown on the right, which is actually done in a very controlled facility, not far from here, just down the street at Canadian Blood Services, where they bind these cells with a small antibody that identifies the stem cells and keeps everything else going through this column. Anything that's not a stem cell will fall to the bottom, and then they simply just release this magnet that would then bring down the purified stem cells, and they're put away, and they're frozen. The next step is for the patient to undergo the ablation. That's the procedure for which we remove the diseased bone marrow. And then once they're at a stage where we're pretty sure all of it is gone, we bring back and we repopulate the body with a brand new immune system. And the results are things that you've heard about, as you can tell from this little diagram here. These were the patients who had lots of relapses prior to the bone marrow transplant, which is the vertical line. And all the little triangles you see here are attacks. And each line on the horizontal here is a single patient. So if you look at patient number 3, look at all the attacks. Every one of those are episodes where the person has lost neurological function for anywhere from days to weeks to months, and may or may not have recovered. And then they had a bone marrow transplant, and then afterwards you can see there's very few attacks. Numbers-wise, there were an incredible number of attacks prior, and just in these 23 patients, and then afterwards, really it was 0. Now those are the clinical attacks. Everybody knows that the MRI picks up lots of other things, and on the right here, these were the MRI attacks, so to speak. All the little triangles representing MRIs that were done that showed new lesion formation. And then to the right of that, all the little black dots here represent times where we've done MRIs, and you can see there are absolutely no triangles whatsoever. Nobody has had an attack now in 16 years since the very first transplant we've done. And these were very aggressive patients to begin with. We measure brain tissue loss because brain tissue loss is bad, and we're trying to preserve brain. And we think the disease slowly chews away at it. People were losing brain at a steady rate. Normal people would lose brain at the gray line that you see here. If you have MS and don't have it treated, you lose brain almost 10 times more, as seen here. And here are patients right in where people are losing brain despite the fact that they're on some type of therapy. The procedure itself causes a temporary little loss in brain tissue, but as we go out here 1, 2, 3, 4, 5 years hence, you can see that the rate of brain loss at the end of the second year was still very much in keeping with even patients who've never been on treatment, very discouraging until you think about when we're going to see the results of a procedure. We do the procedure here. when would you expect to see the change in tissue loss? Well, tissue loss that occurs probably in the first year or two is more a reflection of what happened before, not what's happening in real time. And so the results of what we did at time 0 were not really seen until the 2nd, 3rd, and right out here into the 5th year, you can see patients are losing brain tissue at the same rate as people who don't have MS at all, age-matched controls. What we didn't expect to see is all these improvements. And there was a steady increase in the number of people who actually recovered function, and it started late. It started in about 2 years, but has continued throughout this time. And so not only in the absence of new inflammation are there no new attacks and no progression of the disease, but there seems to be an ability to recover. Whether that recovery is simply dependent on the individual's patient's ability to recover, or tantalizing to think that those stem cells that we put in to replace the red and white blood cells in the body may actually be doing something else. And did these have any tangible effects in them? When you look at this in the patients who progressed or who remained stable or improved, there were some real world changes here. People improved their ability to actually live day to day, and almost 60% of them went back to work, went off of disability, maintained their relationship with their significant others, and even almost 70% of patients went back and got their driver's license, which most of them would have lost because of their inabilities. So that's the bone marrow transplant program. The second study that we've finally completed our recruitment for, and results will be available probably this time next year because we're part of this international project, is to look at the other guys in the bone marrow. This is the support cells of the bone marrow, the so-called stromal cells, and in amongst those are the mesenchymal stem cells. You can identify them because they have this spindle-like shape and they like to stick to plastic. These guys are few and far in number, but they retain some very important properties. You can get them from various sources. They still have some multipotent nature to them because they can differentiate into different types of cells of the body. And they have at least 3 different properties that have been used, at least experimentally. One, they can become any cell of the body that you need, although the chances of that actually happening in humans is very low and the evidence very low. They can promote repair. We've seen them in a lot of models to actually move to areas of tissue damage and promote repair. And they've seen that, and this is part of what stem cells are being used at our center. You may have heard of the project by Duncan Stewart that looks at heart repair. So they can repair any tissue. That's one of the features. But one of the intriguing ones is that they are themselves anti-inflammatory, and that's where they've been used most. So you can grow these cells. You pull them out of a marrow like you would just having a marrow test, and we grow them up in this stem cell facility next to the part of the Ottawa Hospital Research Institute. And after about 2 or 3 weeks, we have millions and millions of these cells, and at that point, we can put them back into people. And so we've just completed. Actually, we have 1 patient left to get their cells. This phase 2 study where we're actually trying to see if doing this process, believe it or not, will change the way MS works. We're looking at, of course, safety of doing this intravenously mainly. We were taking anybody who had active disease, whether they were called relapsing or progressive, and it was a 1-year study, but really the ability to see the cells change things was being measured over 6 months. And then we threw everything else at it. We threw some neuropsychology that you're going to hear from Dr. Walker very soon, whether there's been any change in the cognitive functioning of these patients. Sure, lots of imaging. We have relationships with several other members of the university who do some interesting physiological changes. We're certainly looking at their ability to, on a functional scale, which would be of interest to Dr. Pilutti, who you're going to hear from next. So we don't know what the results of these studies are, but we've certainly thrown the gamut at these patients to see whether or not these mesenchymal stem cells, the ones we have to grow, will have the capacity to change disease. And of course, we wouldn't be able to do that without a lot of people, some of whom are listed here, but most importantly, it's the patients. So thank you very much for your attention.
So stem cells and other types of modalities is one way of looking at MS. And the other is cognitive rehabilitation and mindfulness. And so I'd like to welcome Dr. Lisa Walker, PhD, clinical psych. She is a clinical neuropsychologist at the Ottawa Hospital with academic appointments at the Ottawa Hospital Research Institute, University of Ottawa, in both the Faculty of Medicine, the School of Psychology, and also at Carleton University in the School of Psychology and the Institute of Cognitive Science. So welcome, and we look forward to your talk.
Thank you so much. I would like to thank the organizers for inviting me. It's an honor to be here with you today. I'm a proud member of the Brain and Mind Research Institute. It's a great organization and an amazing group of people. So, and led by David, who's doing great things leading us. I have no disclosures relevant for tonight. So the objectives of my talk are to talk about cognition in a nutshell. Don't have a lot of time to get into details, but to give you a little bit of information. And then I'm going to talk about two techniques that we have that we might be able to do something about the cognitive changes that happen with MS. So, cognition in a nutshell. The walnut is a beautiful example of what your brain looks like. All right, so frequency of cognitive impairment. We know that cognitive impairment affects about 43 to 70% of people with MS. So more than half, in generally, of people with MS will have some changes in their cognition, in their thinking abilities. About 40% will have cognitive changes that I can measure with the test that I give, a neuropsych test. Activities of daily living are sort of mildly to moderately impacted. About 5 to 10% will have more significant changes. These are the changes that you might consider at the level of a dementia, where they're severely impacting someone's ability to manage. Importantly, cognitive dysfunction can happen in any MS subtype. So it happens in the progressive disease as well as in relapsing remitting disease. It even is present in people who don't yet have a diagnosis of MS, so they're in that early stage before they officially meet diagnostic criteria. They might have some lesions on their MRI, but they really don't have a lot of clinical symptoms, but they still have a similar cognitive profile. Okay, in terms of what types of cognition is affected, the biggies are information processing speed and learning and memory. So how quickly people can process information. You can still process it, it just takes a little bit longer to do so. Also with learning new information. Memory is not so much impacted, it's more the learning part. So it can seem like a memory problem, but it really has to do with information getting in to begin with. Other areas can be impacted as well, visual spatial abilities, executive functions, or problem solving or higher order abilities, but definitely processing speed and memory are the biggies. I think this is important to consider. The little diagram on the right shows that the different variables that can impact a person's quality of life. And what we see is that cognitive impairment is one of the strongest predictors of reduced health-related quality of life in people with MS, more so than their physical disability. And I think that's something that sometimes surprises people. But mood and cognition and fatigue, these are things that impact people more than their physical dysfunctions do. The chart on the left shows you all the different areas that can be impacted in someone's life when they have cognitive difficulties. It can affect their ability to remain employed, it can affect relationships, it can affect your ability to drive, it can lead to increased falls because of judgment difficulties, it can affect medication adherence. So it affects many, many different areas of people's life. It has a great impact on quality of life. So that's why it's important for us to find ways of doing something about it. I think the research in MS over the first several years looking at cognition basically was to show that cognition is affected. Now our job is to figure out what do we do about it. So let's talk about cognitive rehabilitation. Everybody can use a little pumping some iron with their brain. There's two types of cognitive rehabilitation. There's remediation techniques and compensation techniques. The remediation techniques are the things that we do to attempt to restore a lost function. So if you have attention problems, Then if we're trying to remediate that, we would give you lots of different exercises of your attention, trying to boost your attentional abilities. The compensation approach is a little bit different. This is more learning the workarounds for the areas of difficulty. It involves changing the environment, changing your way of doing something, adapting your lifestyle to accommodate for the difficulties that you're having. So for example, if you've got a memory problem, you could learn to use Google Calendar to help give you reminders when you need to do something, okay? So that's an example of a compensation technique. So I'm going to tell you a little bit about the research in both those areas. So probably most of the research so far has been in terms of remediation. John DeLuca is a neuropsychologist down at the Kessler Institute in the States, and his group are really the pioneers looking at cognitive rehabilitation in MS. And they use a technique called the modified story memory technique. And this is a technique essentially that teaches people how to learn. So they teach them how to use context, so contextual cues, as well as visual imagery when they're trying to learn words, okay? And they put them in a randomized control trial, and they gave them 10 sessions of this learning how to use this context and imagery to help their memory. It was a very methodologically sound study. It was a randomized control trial where they looked at 86 people with MS that they were randomized to the treatment group or a placebo group where they did another cognitive task but not the task of interest. What they found was that the treatment group showed gains in verbal learning, in everyday memory, and in general contentment in their life. And the family members of these folks reported that their level of apathy had diminished and their executive functioning had improved as well, so their problem solving and organizational abilities. Importantly, those effects were maintained at 6 months, so we know that there's some evidence that these can be sustained over time. What they did find when they looked back at their data was that the folks that had reduced processing speed did not benefit as much from the intervention as folks who had normal processing speed. Another approach, another remediation approach is being put forth by an Italian group. And these folks are using an app that they've developed called Cognate RAC. It's not yet commercially available, but it's in the process of being studied research-wise. And this app involves 3 different working memory tasks. What's important is that the difficulty level of the task is set first by the examiner, and then thereafter, the person themselves sets the difficulty. So if they get a question right, the difficulty level increases. And if they get a question wrong, the difficulty level decreases. So this is an example of what you might see in this app. So each of the rectangles represents a screenshot, okay? So you see that there's the number 4 present in the 3rd position on the page, okay? So you would press the 4 in the red areas and the 3rd position in the green areas to indicate the 4 is in the 3rd position. Then the next screen, you press the 2 in the 4th position. The next screen, you press the 1 in the 2nd position. All right, so that is the 0 back condition, meaning you report exactly what you see on the screen. The second line at the bottom shows the harder condition. This is the 1 back condition, meaning you have to respond with the information from the previous screen. So you see a 4 in the 3rd position, then the next screen comes up with a 2 in the 4th position, but you don't put 2 in the 4th position, you put 4 in the 3rd position. The next screen comes up and you respond 2 in the 4th position, and so on. It's difficult, right? It's very challenging. It's not easy. But that's the nice thing about that is that if you get good at it, it gets harder, and if you are having trouble with it, it gets easier, okay? So it's an adaptable method. So this group did also a rigorously designed methodological study in terms of a randomized control trial. They looked at 28 people using this app, and they were randomized to the adaptive group, meaning that the app adapted to their difficulty level, or the non-adaptive group, where the level stayed constant that was set by the examiner. And the nice thing about this app is that you can do it at home, okay? So they had 5 30-minute sessions per week. Patients liked it. They did it 87% adherence. So 87% of the time they did what they were supposed to when they were supposed to. And what they found was that the adaptive group showed improvement in attention and processing speed. So these are tasks that are similar to the trained tasks. But what was really nice is that they also showed improvement in other areas of cognition. So their learning got better, their verbal memory got better, and their verbal fluency, their ability to produce words, got better. So that is really important. In terms of rehabilitation, we want to see evidence of transfer of task, meaning you don't want to just get better at the one thing you're doing, but you want it to be evident that you're getting better at cognitive tasks in general. So that was the nice thing about this study. 6 months later, the attention and processing speed improvements were maintained. So that's some evidence of the remediation approaches. So let's talk about compensation approaches. This is something that is a little bit newer. So that's one of the things that I'm interested in. And so along with a colleague, we're going to be looking at a program called CogSmart. It stands for Cognitive Symptom Management and Rehabilitation Therapy in MS. It's essentially a program that's been used in folks with brain injury, so traumatic brain injury, with quite some success. And we want to see if it's similarly effective in people with MS. So this program is aimed at improving prospective memory, which is remembering to remember, your attention, learning and memory, and executive functioning. So it really targets all different aspects of cognition. It teaches people how to improve their cognitive skills by using strategies that they can practice in their daily lives. And then when they come to the group sessions, they can troubleshoot what was difficult about that strategy. Is there another strategy that might work better? And the goal is to make the strategies become habits so that they can be something they can use in their daily life. The theories behind this program are the cognitive compensation that we've talked about, so learning workarounds, but it's also about habit learning. There's lots of different memory areas of your brain. The areas that are most often affected by MS are the things like learning a word list, remembering to do something, etc. But habits are procedures. Those things are in deep structures of the brain that are less often affected in MS. So if we can train somebody to do something as a habit, the more likely it is that they'll be able to continue doing that. Okay? And use areas of the brain that are not affected by MS. So this will involve 10 weeks of different topics. So the first week we'll talk about MS in general and what are the typical cognitive areas affected, how does it affect emotions, how does it affect our fatigue levels, etc. And then we get into more specifics. So each week we'll look at memory or attention or planning and goal setting, etc. Each session is going to include psychoeducation about the topic, how it relates to MS, and then introduction of techniques to assist with particular symptoms. We'll give opportunities in the sessions to practice these techniques and discussion. It's going to be a group format, so people will be able to say what worked for them and what didn't work for them. And of course there will be homework. All right, so I have no data to report on that because it's something we're just starting. So hopefully if you hear from me next year, I'll be able to tell you something more about that. So aside from cognitive rehab, something that's becoming more and more in popular culture is mindfulness. So just to remind everybody what that is, mindfulness, according to Kabat-Zinn, who's one of the founders of this approach, is paying attention on purpose in the present moment, non-judgmentally. Thank you, Heather, for this slide. So this essentially means that you don't worry about what you did yesterday, you don't worry about what you have to do tomorrow, but you're really in the moment. So as you're sitting here, you're listening to me talk and you're not worried about, whether the babysitter's gonna think you're late when you go home, okay? So that's what mindfulness is. So one of the things we looked at with our group was trait mindfulness. So the characterological trait of being mindful. So are you just naturally mindful or not? Our objective was to see if we could demonstrate a relationship between trait mindfulness and wellness variables in MS. So we had 47 people with MS complete an online questionnaire that looked at mindfulness, mood, quality of life, fatigue, their sense of their cognitive functioning, and their report of pain. And what you see, it's a busy slide, but essentially the variables on the left are the different mindfulness aspects. So your ability to observe, to describe your emotional experience, to act with awareness, etc. And what we found was that the more mindful you are, as a characterological trait, the less depressed you are, the less anxious you are, the less pain you report, the less fatigued you are, and the less you report cognitive symptoms. So just your ability to be in the moment and not worry about all the excess stuff that's going on in our lives is helpful for your mental well-being. We also looked at its relationship to quality of life, and what we found was that the more mindful you are, the higher you rate your quality of life, particularly as it relates to your emotional functioning and your mental health. So this is really encouraging, and so now that we know that mindfulness is something that can be beneficial, can we manipulate it? Can we make people more mindful? So that's where the research literature is going now. So a group in, I believe they're in Australia, Bogosian's group, looked at whether or not a mindfulness intervention, something like mindfulness-based stress reduction, could improve people's functioning. They delivered the mindfulness intervention by Skype, which is important for people with MS who have mobility restrictions. It's a nice thing to be able to do it in your home. What they found was that the intervention reduced distress and the effects were sustained at 3 months. It helped with mood, it helped with pain, it helped with fatigue, and the impact of MS symptoms. They also did a cost-efficacy analysis and found that it was cost-effective. So there's reduced healthcare costs associated with this intervention. But what about cognition? They didn't look at cognition. We know that mindfulness research in other areas has shown a benefit to cognition. So healthy individuals who undergo a mindfulness intervention are better at their visual spatial processing, their working memory, their executive functioning, they're more flexible in their thinking. Older adults with cognitive dysfunction as well are better in terms of their memory. We know that meditators in general have better attentional abilities. And there was an excellent study about enrolling people with Alzheimer's disease and their caregivers. And this was a pretty impressive study that did a mindfulness intervention over a 2-year period. And what they found was that those in the mindfulness group had a less precipitous decline in their cognition, which was pretty exciting. So, in terms of what are we seeing with cognition in MS, this is a brand new study just out this year looking at a mindfulness-based intervention in a group of severely fatigued people with MS. It's not a randomized control study, it's the early days in this type of research. They did a mindfulness-based cognitive therapy intervention, and it was an 8-week thing, 2.5 hours per week, spread over 10 weeks. And what they found was a beneficial effect on fatigue. So fatigue was reduced, and that remained stable at 3 months. But from my perspective, what was particularly interesting is that they also reported reduced cognitive complaints. The drawback, I guess, of this is that this is a subjective report. They didn't measure cognition objectively, and so I think that's the next step, and that's something we'd like to do in our group as well. But it's information that's giving us some hope that mindfulness interventions might be helpful. So, what are my take-home points? One, we know that cognition is often affected in people with MS, but there are interventions that may help. Cognitive rehabilitation using remediation approaches can be helpful to improve cognition. We need a little bit more information still on the compensation techniques, so we're working on that. We know that trait mindfulness is associated with better mental health, better quality of life, and better perceived cognition. And we know that mindfulness interventions might lead to better subjective cognition, but we still need some work to do on the objective part. So we can all take a lesson from our pets that know how to be in the moment when the rest of us are worried too much about what's going on. And lastly, we can take some advice from Winnie the Pooh, who's a master at mindfulness. All right, thank you very much.
To continue on, we initially talked about the brain and stem cells, then we talked about the mind, and now we're going to talk about the body. So Dr. Lara Pilutti is an assistant professor in the Interdisciplinary School of Health Sciences at the university and is part of the Faculty of Health. So, Dr. Pilutti.
Thank you so much all for coming this evening, and thank you for the opportunity to share a little bit about what we're doing in our lab and about the role of physical activity and exercise for people with MS. So just a brief outline, I'll start with talking a little bit about what we know relative to the safety and the benefits of physical activity and exercise training in MS. We have Canadian MS physical activity guidelines, so I'll share some of the research that went into developing those and what they specifically state. I'll talk a little bit about how active people with MS are, what we know about certain types of MS relative to activity, and then what are some of the solutions that we are focusing on for increasing the accessibility of physical activity and exercise to meet the needs of everybody who's living with MS. So I'd like to start focusing on the history of exercise for people with MS. So it was originally believed that exercise was contraindicated for MS, and there were a lot of fears that exercise would cause an increase in MS symptoms or exacerbations or relapses, such as Dr. Freedman pointed out earlier. Some of the seminal work in this area really came into play around the mid-1990s from a group at the University of Utah that published one of the first randomized controlled trials on an exercise training intervention. And they showed that exercise training was safe in this group of people with MS, as well as a number of benefits relative to improvements in people's fitness, such as things like their aerobic fitness, their muscular strength, as well as benefits for symptomatic outcomes like fatigue and quality of life. And so this really paved the way for a lot of research over the last 20 years or so that's developed some of the benefits of exercise for people with MS. And we now have many clinical trials as well as many major reviews that I'll focus on highlighting some of those benefits. However, I think there's still a little bit of concern in this area. So the MS Society of Canada conducted the MS Wellness Survey in 2015, and they reached out to people who were living with MS in Canada about their beliefs about wellness behaviors, so particularly physical activity and exercise, as well as diet and emotional wellness, similar to the topics that Dr. Walker shared with us. And this survey revealed that almost 20% of people with MS in 2015 were still worried that activity would make their MS worse. So I'd like to highlight one paper first relative to the safety of exercise. And so this is a review that looked at all of the randomized clinical trials, so high quality evidence in terms of studies of exercise training in people with MS, and was published just a few years ago now. And so this included about 26 studies of exercise, and we looked at the rate of relapses or MS exacerbations, where people experienced these flare-ups or increases in disability. And we also looked at adverse events. And what this showed, looking at collectively all of these studies together, is that people who participated in exercise, about 5% of those people experienced relapses in this study, versus those who didn't participate in exercise, there were 6%, around 6% of people experienced a relapse. So collectively, this showed us that there was really not a huge difference in terms of the rate of relapses when you participate in an exercise program. So this provided some evidence relative to the safety of exercise. And then we also looked at adverse events. And again, fairly similar rates between people who participated in exercise versus those who didn't. So the no exercise group, about 1% of people experienced an adverse event versus people who exercised, about 2% experienced an adverse event. And this is not uncommon when we think about somebody who's starting a new exercise program, who has been sedentary and not very active. It's not uncommon to experience some adverse events. And most common adverse events included things like muscle soreness or a little bit of fatigue initially with an exercise program. So not atypical from what we would expect, and supports the benefits and the safety of exercise for people with MS. So to collectively summarize what we know from those larger studies, those systematic reviews and meta-analyses of exercise, we see that some of the strongest evidence for the benefits of exercise for people with MS are related to fitness outcomes. So these are things like your ability to improve your aerobic fitness or your endurance, your muscular strength, And we know that these are really important outcomes related to overall health as well as functioning in everyday life. Also fatigue, which is a very common symptom that's experienced by people with MS. We see some fairly strong evidence for the ability of exercise training to decrease symptoms of fatigue. Similar benefits we see also with things like mobility, particularly improving walking speed and walking endurance, balance, symptoms of depression, which we know are common in people with MS, overall quality of life, which we've heard already, relative to the importance of this outcome. What we know a little bit less about is what are the effects of exercise on outcomes like cognition that Dr. Walker spoke about earlier. So this is a newer area of research relative to exercise training, and we're just starting to see some of the evidence in this area, but right now it's fairly inconclusive. Also, one of the potentially most important outcomes, and an outcome that's been a focus in recent years, is whether or not exercise can really modify the course of the disease. So can we prevent additional relapses? Can we prevent some of these flare-ups and outcomes that we might see on MRI, like Dr. Freedman shared? So based on the evidence and what we know, in 2013, we took this collective evidence and created the Canadian Physical Activity Guidelines for adults with MS. And so these guidelines suggest that people with MS should do about 30 minutes of moderate intensity aerobic exercise, or what we might call cardio type exercise, twice per week, and then strength training exercise for most of our major muscle groups, also twice per week. So those are the current guidelines available through the MS Society of Canada, as well as the Canadian Society for Exercise Physiology. Now, despite these benefits, despite having these recommendations about what we should be doing for exercise, we know that rates of physical activity in people with MS, when we compare these with the general population, are still pretty low. So this is a study that looked at about 800 people with MS collectively and objectively measured physical activity, so using motion sensors, so something like a Fitbit, but at the research level. And we see here that on average, people with MS are less active than people who don't have MS, and this is fairly consistent across a number of different trials. But we also see some important patterns in physical activity levels relative to the different courses of the disease or levels of disability. So we see that people who have progressive MS, either primary or secondary progressive, are less active than people who have relapsing remitting MS. And then we also see a fairly linear decline in physical activity levels as we increase in disability. So as we move from using no assistive device to a cane to a rollator, we see a linear decline in levels of physical activity. And so, not surprising, there are likely many barriers to physical activity experienced by people who have MS, particularly those with progressive MS or more severe disabilities, such as the physical limitations that accompany the disease. And as these progress, we know that we see greater limitations, and that corresponds with those declines in physical activity. We also know MS symptoms or other health-related concerns, such as comorbid health conditions that people with MS might experience, might limit participation in physical activity. Also, the accessibility sometimes of programs where people might be exercising, might be accumulating their physical activity, may not be accessible physically, or the environment might not be conducive for people with MS to exercise. Again, we're referring back to the MS Wellness Survey. About 30% of people, Canadians with MS, responded that they can't access facilities for physical activity. So that's a major challenge. And that's something that we try to address in our research program. So collectively, the current scope relative to physical activity and exercise, we know there are some benefits there. However, it hasn't focused a lot on people with progressive MS or people who may have more limitations to accessing physical activity. So we need to look at increasing the accessibility. So what does that mean? If we think about our physical activity guidelines and accumulating exercise, that aerobic exercise, that might be going for a walk for many of us. However, for people with MS who may be more limited in their physical abilities, that might be a lot more challenging. So we look to solutions that involve adapted exercise modalities, so things like recumbent steppers or arm crankerometers, and I'll touch on these in just a moment. So these are some of the ways that we try to increase the accessibility by looking at different modalities. A lot of the evidence relative to the benefits of exercise have also been established in very controlled, supervised exercise settings where you may have one-on-one care from somebody who is providing you your prescription of exercise, giving you the information of what to do, how to do it, and you're doing it in a supervised facility. Again, that might not be an option for everybody with MS, and that also really limits the reach of the benefits of these exercise interventions. So we also look to approaches that increase accessibility by changing how we are delivering the exercise. So things like the delivery of rehabilitation through the internet or physical activity programs that are delivered through the internet to increase the accessibility. So I'm just going to touch on some of these results and a few different types of these accessible modalities of exercise. So we've looked at this literature over the last year or so in terms of what are the benefits of exercise for people with MS with more severe mobility impairment, what types of exercise and approaches are being tried here, as well as for people with progressive MS. We know this is an area that has not received as much attention. So what are some of these potential modalities and what are the potential benefits? So this is a study conducted out of a research group in Denmark that has done a lot of work relative to exercise interventions in people with MS. And they examined an upper body exercise training program. So an upper body arm cycling program, again in a supervised setting for this study, and exclusively in patients who had progressive MS. So I'll just note the EDSS level, we've seen that in a couple slides already, so that refers to the level of disability, in this study 6.5 to 8. So those are people who are using a cane, a walker, a roll leader to assist in ambulation. So it's a 4-week inpatient rehabilitation program, again upper body aerobic exercise. And one of the key things from this study is this really showed us that people with progressive MS at this higher level of disability were able to exercise at a fairly high intensity, and one that we know is associated with important cardiovascular and aerobic benefits, which is really important for our overall health. Moving on, one of the other types of adapted exercise that's been used probably most commonly with this group with more severe disability is body weight supported treadmill training. So it's a treadmill with an overhead support harness system that allows somebody to be suspended over a treadmill such that a portion of their own body weight can be offloaded, making it easier to walk or walking with assistance, either that of therapists or with robotic devices. So far there's about 8 studies that have been done, again at this higher EDSS level, and we do see improvements relative to things like muscle strength, mobility, symptoms of fatigue, and probably most importantly, independence in performing everyday activities. So this is translating into the tasks that we're doing every day. We've also taken a look at the recumbent stepper. We know that some of these modalities, such as body weight supported treadmill training, are only available in a few facilities, but the recumbent stepper is becoming a more popular modality in a lot of different community-based programs. And so again, we're looking at patients with progressive MS at a higher disability level. A 12-week program here that we examined, we found improvements in symptoms of fatigue as well as quality of life. We also compared, so this was looking at recumbent stepping versus the treadmill, and people really preferred using the recumbent stepper. So always important to get that feedback relative to the types of these modalities in terms of what patients are prefer to use. Functional electrical stimulation cycling. So this is a new modality that we focused on a lot recently in our lab. There's been very few trials to date looking at this. This is a type of exercise that has been used primarily in patients with spinal cord injury and stroke, and now we're seeing a lot of this work being applied to people with MS. So there's some early evidence, but still early on, very few trials here. So we just finished the first randomized controlled trial relative to FES cycling for people with MS. both progressive and relapsing, but again in this higher disability level. We determined it was safe, it was a feasible modality for us to conduct, and again, people were able to exercise at a fairly high intensity. Some benefits initially that we've seen have been for things like physical fitness, symptomatic outcomes, even cognitive improvements with a 6-month intervention. So we're excited about the next steps in this line of research and moving to a larger trial. Lastly, I'm just going to touch on changing up how we deliver exercise interventions. So in collaboration with some of our colleagues at the University of Alabama, we've been working on an internet-delivered physical activity intervention. And so it's based on theories of social cognitive theory and providing people with MS tools and techniques for changing just your everyday behavior to increase your daily steps, essentially. So participants are provided with a pedometer and access to a dedicated study website to learn about how to just change their everyday activity. So the most recent version of this trial, we've seen that it's effective for increasing physical activity, so about 30 minutes per week more of that moderate to vigorous intensity physical activity. And we've also been showing that it reduces daily sitting time of about 99 minutes per day, which is really important. We've heard a lot about the challenges of decreasing daily sitting time, and we know that everybody is sitting for very long periods of time and it has important health consequences. Other benefits we found are relative to symptomatic outcomes, mobility, and cognition in certain types of patients. So just to conclude, we know that there are benefits of exercise for people with MS. We also know that the scope of evidence is really limited, and we need to be focusing on certain groups of patients with MS to increase that accessibility of exercise, as well as changing the rates of physical activity and seeing if we can develop more appropriate solutions to increase the accessibility and reach of exercise. So we're really focused on developing optimal prescriptions of exercise, finding out what the best modalities are, and how we can deliver them to benefit the most people living with MS. So just like to conclude, acknowledge my research team here in Ottawa, our groups, the Clinical Exercise Physiology Lab, our collaborators, and most importantly, the patients that take part in these studies. Thank you.
We can have a session of Ask the Researcher. And while they're getting settled, let me just say that you know, Laura, Mark, and Elisa are the tip of the spear when it comes to MS research here in Ottawa. So there's about 24 researchers that get together and discuss all the exciting research that's going on. We've chosen them for obvious reasons. Their research impacts you more directly and more visibly, but there's a lot of things that are happening in the background that set the foundation for future therapies as well, and hopefully in the next years we can highlight them as well. So what I'd like to do now is to offer all of you a chance to ask questions. I'm sure there are many, and so there is a microphone there, or I can go around and bring it to you if you desire. So can we start? So.
About the window within which stem cells might be effective, both in terms of age and duration of disease.
Can I just repeat that? So your question, because most people can't hear, is the window of opportunity for stem cells and its effectiveness, I think was the essence of the question.
I'm not sure if the question is referring to the age at which you derive the stem cells, or the age at which you would be given the stem cells as a treatment. Is that? I'm not sure which one you're referring to.
Both.
Both, okay.
Yeah. Also the age at which you receive the stem cells.
I don't know if there's an age limit in the ability to obtain stem cells from people. I think they've gotten them from all ages that they've tried. In terms of the replacements, remember I was talking about at least a couple of different types of approaches. One is the approach of removing an immune system and replacing it. and using the stem cells to replace it. That's one. The other is repair. I think that the removal of the immune system and replacement is at a time when there's still very active disease going on. There's no point in doing it once all the fires have stopped burning and the damage is already done. That's the time for a repair strategy, and that's why the second one that I discussed, the mesenchymal stem cell, would be appropriate for that, and that, as far as I know, could be applied at any age. If there's potential there for those cells to repair, there's actually really no way of us knowing what amount of damage is repairable in any individual. We see the deficits. This is a challenge for all of us because we can see people who have less ability to walk, that don't do well on cognitive studies. We don't know which amongst those are looking at the damage that's repairable. I would like to think that there's some that's involved in everyone, but our ability to pick that out and say this is somebody who will benefit from this or not is unknown. So at this point we have to try it on everyone and see if we can't figure out who it is who's going to be benefiting.
What about duration of disease? Does the research say anything about that?
The duration of MS, well, is important because the longer you've had the disease, the better the chances that you've gone through that phase where the strategy of replacing the immune system is come and gone. And the longer you have it, the more disability you have. The longer a disabled area is allowed to be disabled, then you run into other problems that are beyond the nervous system, things like joint contractures and stuff that really we can't do anything about once that happens. That's the body responding to the lack of mobility.
Way in the back there with the glasses.
What is Dr. Freedman, what you think about the study from Southern California about Dr. Longo and his generating stem cells through fasting and mimicking diet?
So the question was a Southern California study about fasting and stem cells.
About what kind of stuff?
A fasting. Stem cells,
By Dr. Longo at the University of Southern California.
Longbow, University of Southern California, fasting and stem cell generation.
I'm sorry, I don't know anything about that.
This is a question for Dr. Walker. If somebody's been diagnosed with MS, but is not yet showing any cognitive problems, would the remediation techniques be any good to prevent cognitive things or to delay them?
That's an excellent question, and I think then you're getting into the area of what we call cognitive reserve. And that's another burgeoning area of research which I could give you a whole other talk on. Essentially, we're learning, not just in MS, but in other illnesses as well, the higher reserve you have, the better you are able to deal with any pathology in your brain. And so by reserve, I mean how much education you have, how socially engaged you are, how much exercise you get, your diet, whether it's a good diet for your cardiovascular system. So all things that contribute to higher reserve are good for your brain. So it doesn't mean you get more brain cells, but it might mean that your brain cells that you have are a little bit more intricately connected, and a little you can afford to lose a few branches before you begin to see deficits. So I don't know that it would improve their cognition. You're getting back to your question, but I think it certainly wouldn't hurt, and it may help fighting off pathology that comes in the future.
Hi, this question is for Dr. Freedman. You've had such phenomenal results with those studies. I'm just wondering if you could describe the timeline that it might become more generally available, maybe specifically for secondary progressive type MS.
So I'm only giving you results of one study. which is the replacement study, a study where we remove the immune system and replace it with stem cells. That has actually, the first attempts at that were done in patients with progressive MS in the hope of trying to bring those patients back. And they have been universally failed to do so. In fact, it almost put a stunt in the entire thought process of using that technique, because all they ended up with were a lot more complications and very little benefit. As you can imagine, progressive patients have less of this inflammatory component that's being addressed by wiping out an immune system. They may have already passed that, and only reparative strategies are going to work. And although we saw repair in our patients, that was the light that was not expected. We think it's repair because it was very close to the time in which the damage was occurring. So if you can get there at that time, it looks like that strategy works. But if it's been there for a long time, as is the case in most people with progressive forms of illness, it's not going to work and just cause problems. What that group needs is the second study, which is ongoing, and we don't have results yet, that we hope to have by this time next year to show whether or not there is any indication that giving mesenchymal stem cells, where there's no chemotherapy involved, there's no removal of an immune system, simply something that was put in to bolster whatever natural repair processes are there. And whether we see results or not may depend, as I said earlier, on how repairable somebody's nervous system is. And as you, I think, come to sessions later this week, that whole theme of knowing what's repairable and what's not is something that looms in all of us who do research with the brain, because we know that the brain gets damaged in many different ways. In MS, it's the immune system. In stroke, it's lack of oxygen and blood supply. In some of the neurodegenerative diseases, some of the mechanisms are known, but the ability to repair it is what's on everybody's mind, and how to do that and who to target that type of therapy is a real quandary for us all.
So if in the next year you get the results of those studies, is it something that might become available in 2 years, 5 years? Is it at all something you can talk about?
Well, the technology is there. It's there now. The problem is the ability to generate cells like this from an individual. We can handle in our institute here 2 people's cells per month. Now think of all the number of people who might need this. There's no way a research facility such as the one we have here is going to be able to meet the demands of that. And if it proves to be beneficial, that's where we're going to need a lot of help from anyone who is able to fund a facility that would then be able to grow those cells. And that's going to take a lot of resources that we don't currently have.
This is another question about the blood cells. Oh no, I'm actually wondering if blood cells, core blood cells from umbilical cord blood cells, would that be any better? Or I know my grandchildren, their parents kept some of their blood cells. Is that a good idea, or is it just a scam?
Well, one of the first studies that were done with mesenchymal stem cells, so you can get these from many sources. One of the easy obtainable sources is in fact the placenta, and you can grow these cells out. And interestingly, because they lack the usual markers of your body, which are normally expressed by most cells, so that if I gave you my cells, you would reject them because they've got my markers all over it. These cells don't have them yet because they're pre-differentiated. So people have tried pooling the cells from placenta and an effort to try to see if they will work under these circumstances. And we did a small study like that a few years ago. The cells were safe, but they didn't seem to do very much. So placenta can derive mesenchymal stem cells. Cord blood is a great source of certainly blood cells that could be used in the future for the individual in whom the cord blood was obtained. So it's for the infant, and that's going to eventually grow into a person, could use those cord blood cells, who knows for what, if they end up with some catastrophic illness. But to use them on somebody other than that person in whom the cord blood came from would be the same as if I gave you my cells. So you run into the problem of a mismatch and rejection, and then that opens a whole other quagmire of problems, because you have to take drugs to prevent you from rejecting the cells, and then it causes all sorts of concern. So it's better when it comes from the same person. You can't see it. Well, even in the front row here, you'll never see this hand. Oh, well,
it's a very, very quick question. It's very quick. How are these mesenchymal cells administered?
How are mesenchymal cells administered in our program? It's simply intravenously.
So you don't drink them?
You don't drink them. That'll destroy them. Your stomach is an acid place. So some people are actually putting them directly into the spine, but the evidence for that is very limited. And I don't know that it has any advantage from the animal model, so we're just using them intravenously.
In the back, why don't you just speak and then I'll try and translate.
Hello, I have a question for Dr. Flutie, and I'm wondering, any evidence to show that too much exercise would be detrimental? Like you mentioned that we often don't do enough, but what if, is there a line that you cross where it's like, okay, that's just too much and you're going to use it?
So the question is there a line in which there's too much exercise? Would that be detrimental?
Yeah, so that's a good question, and something that I think a lot of people ask and are curious about. So often what we recommend is to just really listen to your body and how you're feeling when you're exercising. That's kind of general advice for anybody. I think anything in too much and in excess can be could cause some adverse events, but the progression of exercise should be gradual. It should be something that you build up to over time, and you want it to be a habit that becomes part of your daily routine and something that you're doing as just a regular part of your lifestyle. So making it a gradual progression and finding the types of exercise that work well for you.
Next year or tomorrow, in fact, I'm getting the wireless.
Hi. This question is mainly for Dr. Walker. So you mentioned that you're trying to find objective ways of measuring cognitive ability and, well, the effects of mindfulness, I believe, on cognitive ability. And before that, you mentioned some psychological tests. I was wondering if you might expand on what kinds of tests these are, and to further that, if there are ways to measure cognitive ability by looking at things such as neuroanatomy, for example.
Okay, so we have objective ways of measuring cognition. That's the bread and butter of what I do as a neuropsychologist. Is I have all kinds of tools in my handbag that I travel with me wherever I go in terms of testing people's cognition. So we have objective measures that are standardized tests that are given to many, many people across the age spectrum and different levels of education. And we know what's quote unquote normal for a person of a certain age, a certain educational background to perform. So those are the tests that we use. And so when I was talking about the mindfulness research, there's not a lot of studies yet, very few that have actually used those measures to evaluate cognition objectively. Really, they're relying on people's self-report. Do you think your memory's better? Yes, I do, or not. Okay. And in terms of neuroanatomy and measuring cognition, you were saying neuroanatomy? So there's something called fMRI, which you may have heard of, called functional MRI, where you put a person in the MRI scanner, and while they're in the scanner, they have a mirror on top of the head coil that allows them to see a screen outside of the scanner, and you can project all kinds of cognitive tests onto the screen, and then they have buttons that they can press to respond. And so we've certainly been involved here in Ottawa in some of those studies that look at what areas of your brain you're using when you're doing a cognitive task, and in general, to sum up a very complicated area of research very briefly, essentially people with MS are using more areas of brain, or more larger areas of brain, to do the same task as someone else who doesn't have MS. So even if they perform to the same level objectively on the test that I might give them, their brains look different when they're doing it. So they're using more brain. So we think, and one of the things one of my grad students is looking at is cognitive fatigue. And is that a measure of cognitive fatigue? So one of the things that I hear from the people that I work with MS is that, yeah, I can go to work, but I'm exhausted when I get home and I have nothing left, you know? And so it's one of the challenges of that as a person with MS is, well, what does that mean for your ability to maintain employment? What does it mean when your boss wonders why you can't, you know, do your job as well, and that it takes everything to do the job? And so we're trying to find objective ways to measure cognitive fatigue, because it's so important to people with MS, and it's has such a negative impact on their ability to engage in the things they want to engage in. So fMRI is one of the ways we're looking at that, to see if we can look at what's going on in their brain as they're doing a task, to see if we can quantify something that's a subjective experience. Does that help?
Yeah. Great. One more last question. Oh, two last questions, okay.
You mentioned about building a higher reserve, and you mentioned education and exercise, but you mentioned diet as well. And I just wanted if you could elaborate a little bit on the diet aspect.
So I'm not an expert on diet. Ben & Jerry's is my friend. So I cannot claim any expertise in that area. However, I can say that anything that's good for your heart and your brain is good in terms of what I'm referring to. So a diet that's good for your cardiovascular health. So Canada's Food Guide is an excellent resource, right, to look at what's a healthy way of eating. Not too much fat, not too much sugar, that sort of thing. Sugar's an enemy to your brain. There's studies by Ottawa researchers, Claude Messier with the School of Psychology, also a member of the Brain and Mind, that looks at glucose and its effect on the brain, on brain functioning. So any kind of diet that is a healthy diet. There's no, Mark can probably comment more on this than I, in terms of there's lots of fad diets that everyone says is going to cure your MS, and there's no research to back up any of them with any authority. Essentially what you can do is to just eat well, exercise, all those things in moderation that you hear about a healthy lifestyle is good for your brain.
So a last question up front?
Yeah, for Dr. Freedman, you said that with the stem cells, there is either repair it or replace it in order to help recuperate. When you talk about repairing the cells, what is the process? Is it healing, or I don't want to say anything?
C'est la même chose en français.
Ah bon! Quand vous parliez qu'il y avait une possibilité de bien remplacer les cellules, de les régénérer, ou bien de réparer les cellules, est-ce qu'on parle de la peine de myéline qui se répare?
Mais c'est lesquelles cellules? Oh, I better say it in English, sorry. So the question is, are these cells capable of replacing myelin or becoming the cell that maybe makes the myelin, or is it just going to repair it? I think, first of all, the question is, which cells are we talking about? The cells that we simply extract for replacement of the patients who received the bone marrow transplant, it's intriguing to think that some of them might do that, but we're putting them in such a small number that we've been able to see that only in animal studies. But because we were able to see it in the animal studies, and it was unexpected, so we started looking in some humans who received bone marrow transplants. And in particular, the experiments were of interest because if you can imagine some people with Hodgkin's disease, for example, they have to remove all the disease, and then they receive a bone marrow from somebody else. And in particular, these circumstances were females who received bone marrow transplants from males. So all the cells that are male have a Y chromosome. You can identify it. And surprisingly, unfortunately, some of these people died even though they had the transplant. But when they looked in the brains of the patients, they found neurons with Y chromosomes in them. Now, how could that possibly have happened if somehow the cells that were given to replace the bone marrow weren't somehow entering into the brain and either fusing with the cell that's there or transforming into a neuron? And they've also seen these same Y chromosomes in oligodendrocytes, the ones that make the myelin. So it's possible. It's possible. Whether they're actually functioning to repair is not clear. What the mesenchymal stem cells will do, and we see this in all of the models that have been tested, is they go to the site of damage. And rather than become an oligodendrocyte to make myelin, they actually are releasing factors that encourage the local cells who were sitting around doing nothing to repair what looks like an area of damage. And so maybe it's through their waking up the repair crews that they have their best potential.
Great.
Okay.
I'd like to thank the panelists, Lara, Lisa, Mark, for an amazing thing. While I have you here, just before, because we spent a lot of money on this video, I'd like you to take a look. Every year we do a video on a particular theme. This theme, of course, is not on MS, but it kind of tells you a little bit about what's going on in the brain and mind and our mission. So we'll leave with that, and I really thank you from the bottom of my heart to endure this very crowded situation. Thank you, and enjoy the rest of the evening.
Sometimes it was at the table, you know, that they will drop the fork. Or they say, oh, I'm clumsy. It's normal. We are not 20 years old anymore.
Not only did he make us a leader, he inspired a whole generation of young surgeons who are now practicing minimally invasive surgery across this country.
We all followed him in terms of his enthusiasm, his energy, and we all shared his vision. For me, he was the most important, influential individual in my adult life.
What happens in ALS is that the motor neurons throughout the body degenerate, which results in wasting and atrophy of the muscles throughout the body. So for the patient, that means that they lose the ability to speak, to swallow, and to move. However, their mind remains clear.
He told me, Margot, I did what I wanted to do all my life. My passion is surgery. He did not talk about his illness. In fact, he was a dreamer for his work. The worst it's to see the pain and to see him declining. It was something that was difficult, very difficult.
Being able to help people like Dr. Lara Pilutti and Marco Brousseau, that's why we're so excited about our new neuromuscular clinical research center.
With patients and offer treatments to patients, but at the same time be able to collaborate with basic scientists who have very promising research tracks in ALS.
In patients, what doctors observe is that proteins clump in the spinal cord, and this kills the cells that are controlling our body's ability to move. We've discovered a process involving 4 genes that cause ALS and normally allow the body to get rid of those clumps. And so we're hoping that by targeting that process, we can eventually halt the disease. Another project is focused on stopping the production of these clumps before they start. And we're trying to get that into clinical trials in the next 2 to 3 years.
As a clinician, I think what's very exciting is the opportunity to bring cutting-edge treatments to patients in the setting of clinical trials with scientists like Dr. Derek Gibbings.
Working together, great minds, great expertise, and great experience will help us achieve better treatments faster.
He was always for medical research, so I'm sure that he would have welcomed, that kind of research with ALS trials.
Hello, I'm Alex Trebek, Honorary Chair of the Defy the Conventional campaign. You know, it's people like Dr. Lara Pilutti who help motivate researchers and clinicians at the University of Ottawa Brain and Mind Research Institute to find a treatment for ALS. Won't you please support their important work? Because your gift, believe me, will make a difference. Thank you.